Well, good afternoon, everyone. Welcome to today's Lunch and Learn on trauma-informed psychological treatment for young children and their caregivers, an evaluation of the parent-child interaction therapy. My name's Jessica Stewart. I'm the Executive Director of Family and Community Services, Insights Analysis and Research, also known as FACSIAR, in the Department of Communities and Justice. But before we begin, I would like to acknowledge that wherever we're joining today's webinar from across New South Wales, we're living and working on Aboriginal land. I'd personally like to acknowledge the Barramudigal people of the Darug Nation, who are the owners and First Nations people of the area where I have the privilege of joining you from today. I'd like to pay my respects to all First Nations elders, past and present, and to future and emerging leaders, and I'd like to extend that respect to our Aboriginal and Torres Strait Islander colleagues who may be joining us today. I'd also like to warmly welcome you all to this webinar. We have more than 800 people registering, which is a really fantastic outcome, and it's great to see such interest in evidence and research. So at today's Lunch and Learn webinar, we have staff from Psychological and Specialist Services who will present key findings and practice insights from an evaluation of parent-child interaction therapy in the treatment of trauma-induced child behavioural issues. Our presenters will provide practical examples of case studies involving PCIT, advice on how to best implement PCIT, as well as clinician attitudes to and acceptability of the treatment. After these presentations, we'll have a Q&A session with Elizabeth Hagarty, who's our Director of Psychological and Specialist Services here at DCJ. So if you do have any questions about the presentations, please just pop them in the chat section. At this time, I would like to introduce our fantastic presenters for this afternoon. We have Jessica Warren, who is a PhD candidate with the University of Newcastle and an Assistant Director with Psychological and Specialist Services at DCJ. Jessica has worked with DCJ for 17 years in a variety of positions, including casework, management and psychology. Her PhD research is focused on the treatment of very young children's traumatic stress symptoms. And Rebecca Atkins, who has been working as a psychologist for the past 11 years and currently works for Psychological and Specialist Services as well in providing assessment and intervention for children who have experienced trauma. She's recently completed her Masters of Clinical Psychology, also at the University of Newcastle, and her thesis is focused on better understanding the treating clinicians' perspectives on using trauma treatments within DCJ. It's fantastic to have such experienced practitioners doing practice-relevant research in DCJ, so thank you so much for joining us, and please go ahead, Jessica.
Thanks, Jessica. Thanks for having me along to talk about my research today. I really appreciate the opportunity. So today I'd like to talk about the research that I've been conducting as part of my role within DCJ's Psychological and Specialist Services. The research also became my PhD project, which is now just about completed. The research was all about using a therapy called parent-child interaction therapy to maximise treatment outcomes for young children and their families who are known to DCJ. I'd like to acknowledge all of the people that have contributed to this research project. It definitely would not have been completed without all of their hard work. As you can see, this is both a statewide and international collaboration. So thanks to my PhD supervisors and also to the master's students who help with the various parts of this research project, including Beck, who is going to be talking to you a little bit later on today. So I want to talk about the impact of trauma in very young children. So very young children exposed to trauma will likely experience difficulties in a bunch of different domains in very diverse areas such as attachment, physical health, emotional regulation, dissociative symptomatology, self-esteem, cognition, and of course in their behaviour as well. So in fact, small kids who are exposed to trauma often manifest trauma symptoms in externalizing behaviours. So externalizing behaviours are maladaptive behaviours that are directed towards the child's environment. And the impact of trauma can be missed for these reasons. So treatment may not necessarily be targeted in the way that it needs to be. So instead of focusing on children's post-traumatic stress symptoms, we're focusing on behaviours instead. Little kids need trauma treatments that consider their developmental level and the impact that that trauma has actually had on that development. Small kids are often not good candidates for traditional therapeutic modalities for those reasons. And when we think about recovery from trauma for kids, the single greatest predictor of recovery is the child's access to a safe, stable and secure caregiver. And when we add to this that early childhood development takes place entirely within the context of the caregiving system, it's really important that we use that as a basis for resolution of any post-traumatic stress symptoms. So this is where parent-child interaction therapy comes into play. So PCIT is an evidence-based behavioural parent training program that was developed in the 1970s by Dr. Sheila Iberg. It's a play-based therapy that has grounding in behaviour theory, and it's aimed at increasing the child's positive behaviours while decreasing those negative behaviours. It's for children between the ages of 2 and 7 years old, so that younger cohort of kids who have challenging behavioural problems and their parents. It was originally developed for challenging behaviour problems and not so much for children with traumatic stress symptoms. Standard PCIT treatment has 2 phases. The first phase is called child-directed interaction, or CDI. And CDI aims to improve the child's pro-social skills, help their self-esteem, reduce any problematic behaviours just with positive strategies alone. And it also aims to improve the parent-child relationship. The second phase of the therapy, called parent-directed interaction, or PDI, aims to further reduce any negative child behaviours while also helping the caregivers to learn about how to give effective instructions and to use really safe, fair and consistent discipline techniques. PCIT it's a really super unique treatment. It's dyadic in nature, which means that kids and parents are playing together and children are only ever seen with their parent one-on-one. And you can see here in the photograph that we see the children from behind a one-way mirror. The parent utilises a bug in the ear type device, where the therapist, who is standing on the other side of the one-way mirror, is able to give in the moment feedback and support. So we can help the parent when things are going pear-shaped, live and in the moment, and point out to them to help them notice the effect and impact of their behaviours on the child. Why does it work so well with traumatised children when it wasn't really developed for that purpose? I guess it's promoting repairing that relationship. We alluded to before the impact and the importance of that attachment relationship and that safe and stable caregiver for young children for recovery from trauma. It stops the coercive parenting cycle and it provides consistent and non-violent parenting techniques as well. And PCIT has some seriously great treatment outcomes for children and families exposed to abuse and neglect as well, including reduced parental stress, improved parental mental health, excellent child behavioural outcomes as well. And one of the kind of the very first study that ever looked at PCIT with a population of children who had experienced trauma looked at its ability to reduce further child abuse recidivism. So in the very first study of that, amongst families that received PCIT treatment, there were no reports of child abuse or neglect for about 81% of that sample for 850 days post-intervention, compared with 51% of families who received treatment as usual. But there are some noticeable gaps. Several of the studies focus on parent outcomes only, and there's only actually 2 studies that assess trauma symptoms in children, which we know is particularly important given the propensity for some of those trauma symptoms to be missed because they're identified as behavioural issues. And there actually aren't any studies that assess the impact of PCIT on permanency or parental trauma. Several of the studies talk about the need for adaptations to be made in order to adequately treat trauma symptoms. And the adaptations that are mentioned in the literature most commonly include using PCIT as a bit of a therapeutic adjunct prior to trauma-specific interventions, so like trauma-focused cognitive behavioural therapy, or adding in the components of trauma-focused therapy, such as emotional regulation skills and relaxation. So this is where DCJ stepped in to evaluate a world-first treatment adaptation to standard PCIT. This was a new treatment that included some of the trauma-focused components that were reported to be missing in the previous literature that I've talked about. It added a third phase of treatment that occurs in the middle of the treatment, so after CDI, child-directed interaction, and before the parent-directed interaction. That phase of treatment is called trauma-directed interaction, and it incorporates a bunch of these trauma-focused skills that I mentioned before, including psychoeducation regarding trauma, instruction of the caregiver and how to help the child use emotional regulation strategies, and just helping the caregiver to build resilience in the child by helping them to respond to their child when they are triggered or when they are exhibiting symptoms of their trauma. This was very much a naturalistic evaluation of work that we already undertake in my department. The point of the research was to evaluate change for children who are undertaking parent-child interaction therapy and PCIT with TDI included within DCJ. The research was a way to evaluate business as usual within DCJ. The aims of the research were pretty simple, and we really wanted to determine what was the magnitude of change for children and caregivers, post-traumatic stress symptoms, child behavioural problems, parenting stress symptoms, and caregiver mental health. We also wanted to see how many placement changes and future ROSH, risk of significant harm, child abuse, neglect reports were received for those families who were engaging in treatment. So, consistent with psychological and specialist services practice, families were eligible for services if they were currently in receipt of child protection services from DCJ and were case managed by DCJ. They had reported child behavioural issues and/or significant caregiver stress, and had a child between the ages of 2 and 7 years of age. There was no eligibility requirement of like a minimum level of child traumatic stress symptoms or any child behavioural problems. Children were really only excluded from PCI treatment if they lack the necessary speech and language skills to participate in the intervention in a meaningful way. So that specifically was looking at receptive language skills of less than 30 months of age. And when we sort of found that in the study, what we would do is send the child off for a period of speech therapy before we would have them come back to try PCIT. So those children didn't miss out on a service. There were some caregiver exclusionary criteria, including significant and untreated mental health of the caregiver, intellectual disability of the caregiver, active drug abuse, and any caregivers who had perpetrated sexual abuse against children. They were also excluded from the study. So, exciting part, the results. Participants in the study were 68 families seen for treatment by psychological and specialist services between July of 2019 and October of 2022. There were 14 psychologists across psych and specialist services delivering the intervention in every single district across the state. Children referred for treatment included more males than females, and we had an age range from between 2.09 years and 7.87 years, with a mean age of 5.03 years. I specifically mention this because I think it is like a really amazing find of this study that we're actually getting in earlier, seeing kids sooner, supporting carers sooner than what we've ever probably been able to do before. And children were mostly subject to long-term care orders at around about 69.1% of the sample, and they were placed in care mostly with relatives at about 52.9%. The average number of traumas for children were 5.91, And we had usually between 1 or 2 caregivers in treatment. So we also looked at the average number of traumas for them. So for caregiver 1, that was 8.92 traumas, and for caregiver 2, that was around about 5.2 average. About 35% completed treatment and 44.1% dropped out. These numbers were pretty consistent with what the literature tells us on PCIT and trauma, so it wasn't a massively surprising result. Participants who completed therapy attended roughly about 23 sessions, and families that dropped out usually attended 9 sessions, which is still pretty good. Average treatment length was about 8 to 9 months, and we had more children in the PCIT with TDI treatment condition, around 45 TDI and 23 standard. So some outcomes. This is what we're all here for. So for child outcomes, we were specifically looking at changes in post-traumatic stress symptoms and changes in child behavioural problems. We found it had a significant main effective time only, which means that there was a significant decrease from pre to post treatment for all outcomes, but there was no effective treatment type. So both treatments were had similar results. But as I said before, we had a really large attrition rate in this study. So what happened for families that didn't actually complete treatment? In PCIT, it's unique for a lot of ways, but another way that it's unique, you're actually monitoring treatment efficacy with psychometrics regarding child behavioural issues at every session. So you're actually able to obtain data for treatment outcomes for children who don't complete treatment because you have the previous session's data. So for the 44.1% of people that didn't complete treatment, there was a significant main effective time only for children's problematic behaviours, which means that there was a significant decrease in problematic behaviours for children, even when they didn't complete treatment. And when we looked at that by treatment type, those children that were in the TDI treatment condition actually fell below the clinical cutoff for that particular measure, whereas the children who received standard PCIT treatment and dropped out did not fall below that clinical cutoff. So another interesting kind of finding. We were really interested in caregiver outcomes for a few reasons. The first is obviously that the caregiver is so incredibly involved in the treatment of their child that we thought there must be some positive effect for them. But we were also interested in the outcomes for caregivers because of the research regarding adverse childhood experiences. And Felidi's study from a few years ago now, 52% of people had experienced at least one ACE. There's also another study that said rates of mental health issues amongst parents was pretty high in an Australian sample. Around 23.3% of parents had a mental health issue. Also, rates of ACEs amongst foster caregivers, 68% of foster caregivers report having at least one ACE. Is also quite high. And then there are some additional studies that talk about caregivers of maltreated had higher rates of parenting stress and more clinically significant post-traumatic stress symptoms as well. So it was critically important for us to see if there was any change of caregivers in this study relating to mental health, parental stress and post-traumatic stress symptoms. Again, we got a significant main effective time only for caregivers in relation to post-traumatic stress symptom reduction and generalised stress. We also wanted to see what the impact of PCIT or PCIT with TDI treatment was for further child abuse reports and permanency. We looked at how many child abuse neglect reports were received for individual children at 6 months post-intervention. And you can see here that most kids had 0 reports or 6 months at 6 months post-treatment. And for the permanency outcomes, we looked at the number of children who had a placement change in the 6 months post-intervention. You can see in the numbers here that most children did not experience any placement changes post-intervention either. I would actually really like to talk about a case study for a little boy that I treated a couple of years ago now. Seamus is a 3-year-old boy who was referred for PCIT with TDI treatment. He's a case study that's actually been published. So if you would like to read more about him, the reference is here on the screen. And I believe the lovely people at FACSIAR will be providing a copy of the case study with other resources from today's Lunch and Learn as well. Seamus had a really lengthy history with DCJ despite his relatively young age. He was exposed to drugs prenatally, methamphetamine, I believe. He had been exposed to his parents' drug and alcohol abuse and domestic violence. He was also physically abused. And then at the age of 2, he was taken into care as a result of those concerns. He was placed with a relative carer, and that was the only placement since he had come into care. But he'd also been in that placement around about 6 months by the time a referral was made to Psychological Specialist Services for some intervention. And then what we kind of learned about Seamus was that he had a variety of different kind of problematic behaviours that were reported. And the casework team were really keen to get him some therapeutic intervention around that. Seamus would excessively cry and really struggled to regulate his emotions, which often resulted in him biting and scratching at himself, so engaging in some sort of self-injurious behaviour. He had really significant separation anxiety, so he would cry and scream at daycare for at least 2 hours after drop-off, which had been occurring for a very long time. So you can imagine that his daycarers were really worried about him, as was his carer. He was very fearful of loud noises. That fearfulness of loud noises, even when the noise would stop, he would be very kind of on edge for at least an hour or 2 after that. He would startle at very soft noises. One time in the therapy room, I dropped a pen on carpet, and you can imagine that really doesn't make much of a noise at all, but he was very startled by that. And he was also startled by any sort of sudden movement. So if the caregiver got up quickly to find a new toy to play with, he would be extremely dysregulated. He had a lot of general fear that just resulted in him being very reluctant to play with others, and was also very hypervigilant, very watchful of his environment and other people in it. And unsurprisingly, he was described as being very inattentive and unable to focus, and had lots of issues with following instructions. The behaviour was problematic across environments and also for his entire family. The caregiver was really considering relinquishing care due to the impact it was having on her family. PCIT with TDI was determined to be the very best course of treatment given the child's traumatic stress symptoms, difficulties in social situations, and his problematic behaviours. This is a line graph of the Iberg Child Behaviour Inventory, or the ECB, for Seamus. So this ECB, talked about this a few slides back. The ECB is a measure of problematic child behaviour. It's administered at every single session in PCIT. Administration of the ECB really allows the clinician to track progress of the child's behaviour and really helps to target the intervention based on the data that has been obtained. The top red line here is the clinical cutoff. So a score above that line indicates the child has clinically significant behavioural issues and they require intervention. The second dotted line is a line that indicates the discharge or graduation threshold. So kids need to be below this line before we get to discharge them from our service. The black vertical broken lines just indicate the different phases of the intervention, which we talked about earlier. And for Seamus, you can see how quickly we start to see behavioural change using PCIT with TDI by session around about 5 or 6. We have a reduction in behavioural issues that is below the clinical and discharge cutoff. And there are some, obvious peaks and troughs here, but for the most part, we maintain sub-threshold symptomatology for the duration of the treatment. This is a graph of the trauma symptom checklist for young children, or the TSCYC. This measure is designed to assess trauma-related symptoms in young children between the ages of 3 and 12 years of age. And it's providing a really detailed evaluation of post-traumatic stress symptoms, as well as other symptoms as anxiety, depression, anger, abnormal sexual behaviour. The black dotted line here indicates clinical significance. We administered the TCYC at pre and post treatment, but we also did it at the end of the first and second phase of the treatment as well, just to see how traumatic stress symptoms responded to each of the different phases. We can see that trauma symptoms did not fully resolve until post-TDI. So until we'd done that trauma work, we didn't get that full resolution about 2/3 of the way through treatment. However, there was a rise in post-traumatic stress avoidance symptoms post-TDI, which were attributable to a really problematic family contact visit that occurred. But you can see at discharge, all scores were below the clinical threshold. And I always think it's really nice to talk about not just what the numbers say and what the graphs are, but what are some qualitative outcomes? How did this kind of change Seamus and his carers' lives and his family's life? He was more engaged with friends and group activities at daycare. He had a reduced startle reflex, was far more willing to explore his surroundings than he ever was before, and kind of showing some like attachment related behaviours in kind of using his carer as a safe base to do that. Improved functional pre-academic skills. He didn't know any colours, shapes, he couldn't count at all. So he was able to do that post the end of therapy. And he attained different concepts like forward and backwards. So we actually also helped to improve his vocabulary, and just keeping in mind that he didn't actually have any other types of intervention at this time. It was just parent-child interaction therapy. He had a much greater willingness to speak and engage in conversation, and he was discharged from therapy with no additional intervention required. One of the kind of funny things that happened with this kid is that this particular caregiver, she had 5 kids, of which Seamus was one, and she was always talking about how difficult it was to ferry all of those children to all of their various activities, and was quite reliant on family to help her out. And she let me know that her family were really, really reluctant to ever have Seamus in their care because of his behaviours. By the end of treatment, everyone was fighting over Seamus and wanted him to be the one that was babysat, more so than some of the other kids in the home. So that was a nice outcome. But finally, and perhaps the most exciting of the treatment outcomes, is that at the beginning of treatment, the carer was considering relinquishing care of Seamus. But by the end of treatment, the carer was discussing her plans to have Seamus be placed with her permanently under guardianship orders. And about 6 months ago, I believe those guardianship orders were granted around about 12 months after treatment was completed. So really nice outcome for Seamus. Here are a couple of references that relate to PCIT and a couple that I spoke about during today's presentation. And just some information, you know, my email, I think it's going to come up on the screen in a minute. There we go. That if you need to get in touch, want to ask any questions or anything like that. But I'm going to hand over to Rebecca now, who's going to talk to you about her master's project.
Thanks, Jess. I feel very fortunate to be a part of such an amazing study and really being able to make a contribution for such a worthwhile, yet, as we know, a very vulnerable group of young people, that being children in child protection system. So I'd like to acknowledge the contribution and also the hard work from my primary supervisor, so Dr Tanya Handstock and Jessica Warren, in designing and completing the research project. So I'm just going to be sharing some brief insights about my research that was completed as part of me completing my Master of Clinical Psychology at the University of Newcastle, believe it or not, as a mature age student. I was lucky enough that this research could be completed in my area of specialty and that I had the support from Psychological and Specialist Services and FACSIAR. So my study was focused on hearing from child protection psychologists, so those that are sitting in the therapy rooms with children and families day in and day out, and hearing about their experiences and using both PCIT and PCIT with TDI in their work with families. So, as we know, the impacts of childhood trauma, as Jess has outlined, are significant, and if left unresolved can have huge impacts for young children well into adulthood. So there really needs to be effective evidence-based treatment for young children. It's crucial. So psychologists within a child protection agency are more uniquely placed to be able to provide their valuable insights about using a well-known and evidence-based treatment with children and caregivers. So there's only been a handful of studies so far that have actually asked those that are sitting in the room with families what they like and dislike about the training and the treatment itself. And if we're able to have those really important conversations with those directly working with families and children, we can help bridge that gap between research and practice and be able to better understand some of the common challenges in using this treatment within a child protection system. I do want to pause here and give a shout out to such an amazing, skilled, diverse and innovative team of psychologists that we have here in DCJ. So on the International PCIT website, there are already 22 countries around the world that are using this therapy. Under the Australia tab, you'll find that in amongst the trained Australian therapists, there is an overwhelming number working right here in our department. So go team. So we were interested in finding out about how psychologists felt in using PCIT and PCIT with TDI within the unique system being child protection system. So what barriers could be addressed in training and implementation so we could improve those treatments? And also we were interested to know whether PCIT with TDI was viewed as more favourable because of its trauma adaptations. So we used an existing survey. We made some changes. It's known as a CUSP. We included questions such as, do you think that PCIT and PCIT with TDI are appropriate treatments for trauma? Would you like to change the length of treatment? What would you have liked to be different about your training? And what types of barriers did you experience in implementing PCIT and PCIT with TDI? And the list goes on. So we had about 20 responses from PCIT psychologists. We only had a small amount of psychologists trained in PCIT with TDI because of its pilot status. However, we were able to get 5 return surveys. So the results from both groups were overwhelmingly positive. So all participants from both PCIT and PCIT TDI rated these treatments as an appropriate and favourable treatment for trauma symptoms. In the adapted PCIT group, 100% indicated that they agree or strongly agree that the treatment decreases child trauma symptoms, decreases child disruptive behaviour, lowers parental stress, and increases parent-child warmth. 100% of psychologists indicated that they agreed that this treatment also decreased carer trauma symptoms. Once again, the qualitative feedback from both groups was really positive. In terms of training and consultation, one clinician wrote that their trainers were very helpful and knowledgeable. They were also non-judgmental and respectful in their teaching approach. Psychologists described having opportunities to have group consultation and direct feedback as really useful in their skill development. One psychologist from PCIT wrote that they would have liked more training on managing trauma symptoms, and there needs to be more of a focus on how to implement it with a traumatised population. When we asked psychologists about their satisfaction with the treatment protocol, those in the PCIT group stated, teach sessions are good, parents appreciated uninterrupted child-free time to learn the skills and ask questions about the upcoming coach sessions. Another psychologist wrote that coaching has been going well and parents and carers seem to respond well to that instant feedback. PCIT with TDI were also positive about the protocol. One psychologist wrote, TDI is excellent. It provides therapists with a standardised way of delivering PCIT for a traumatised population. The survey also provided useful opportunities for psychologists to identify common barriers to being able to use PCIT and PCIT with TDI to its full potential. So the agency barriers that were identified were not uncommon when we consider the existing international studies from the Netherlands and America. PCIT, as Jess has mentioned, requires some really quite unique resources, such as a two-way mirror and an earpiece. This study was also completed during the COVID lockdowns, so with many psychologists having to rely on internet connections and carers being able to have appropriate access to those resources, such as headphones, earpieces, and a variety of toys. So the family barriers in implementation were also similar to the Dutch and American papers, in that therapists often had more difficulty implementing this treatment with families who had multiple psychosocial barriers. So in our study, there were several instances where psychologists identified that both carer and child trauma was a barrier to implementation. So this finding really highlights the importance of considering the functioning of the family unit and being able to identify and also support carers who are dealing with their own trauma. Thank you for listening, and I'll now hand back to Dr. Jessica Stewart.
Thank you so much, Jess and Rebecca. That was really fantastic presentations, and it's great to see the acceptability of the program as well as the positive impact that it's having. Just a reminder before we move to the Q&A session, if you do have a question, please pop it in the chat. We'll get to it at the end. So we'll now move to the Q&A session with Elizabeth Hagarty. Elizabeth is the Director of Psychological and Specialist Services here in DCJ. Elizabeth is a registered psychologist, certified change specialist, and is currently undertaking a Masters of Organisational Psychology. She has gained extensive experience working across different sectors, including NGOs, private organisations and government departments. Elizabeth has dedicated her work to improving the mental health and wellbeing of those most vulnerable, with a drive and focus to deliver evidence-based models of care. So welcome, Elizabeth. Again, it's terrific to have this opportunity to speak with you all. So we might just move to a few questions. So what does it mean to have research like this being undertaken in your division, where you're also delivering such important services to our clients?
Thanks, Jessica. I might be a little bit biased, but it's great to be able to share the knowledge gained by our staff in undertaking research. We're in a very unique position of being able to add to the knowledge base that works within the child protection system. We want to, and we should be absolutely addressing the gaps, some of which have been noted today. It shows the department's deep commitment to improving the outcomes and experience of children, young people, family and carers. Research helps us to hold on to the hope through applying evidence-based practices, and we can make the impactful changes. There's an absolute appetite for us to ensure that our service is contributing to the research in child protection and out-of-home care. And we actually see ourselves as having a key role in changing the future state of the child protection system. We know that the earlier we can intervene and support a family, the better the outcomes. So it's important for us to explore exactly how we can do that, because what we're doing today really does improve tomorrow. It's been beneficial for us in several ways. It's helped us to continue to understand the needs of children and families and gain insights into their experiences. It's also supported us to evolve our service to make sure that we continue to meet the needs of the children and young people. So that's included for us expanding into multidisciplinary teams. We do have some linked trauma healing services, and also the development of training programs and packages to support the broader service system, all of which collectively can help us increase our mental health literacy of children and young people in out-of-home care and child protection. I'm actually incredibly proud of the work that we do, and knowing that we're contributing to research whilst at the same time concurrently supporting and empowering those most vulnerable is important. You've all heard from Jess and Rebecca's today, and their research has been integral in ensuring that our service evolves in line with the research. We also have several other master's studies and PhDs in psychological and specialist services in areas such as positive behaviour support and therapeutic supports and treatments to meet the social and emotional needs of Aboriginal children, young people and families. So essentially, undertaking research in our division helps keep us on track. It honours those that we support, and it really lifts us into a space that improves the quality of care that we provide to children and young people.
It's terrific, thank you. And how would you describe how you use the results of your various research projects to inform practice?
I think we spend a lot of time exploring the results and considering how do we transfer that to practice. So I think that's sometimes the tricky part, is that we do some research and we think, well, what do we do now that we have these results? So for us, we take it into consideration when making decisions about the interventions that we use, our policies, our procedures. It really creates a solid framework for us as a service to ensure that our approaches are effective, they're efficient, and that they continue to promote positive outcomes for the young person, because ultimately at the centre of this is the children and young people that we serve. And we know that there is a high demand and a lack of mental health supports for children and young people. And so what we want to make sure we are doing is that we are using these results to help us ensure that we are targeting our service to get the best outcomes, because the best outcomes means that the trajectory for the children and young people's mental health and wellbeing improves, and that they can go on to have the fulfilling lives that they so rightfully deserve. Specifically for us, PCIT is now offered as a standard treatment option within our service, and it's been built into our model of care along with a number of other core modalities that we do use. And it's helped us to really have a targeted approach for younger children. And across the state, we have approximately 26 staff that can deliver PCIT. More recently, actually, just a few months ago, we extended this research and we did some further training into child-adult relationship enhancement. So it's a care training. So CARE is a group-based training program that's based on PCIT for any adult who is a caregiver role. So it doesn't necessarily need to be a foster carer or a kinship carer. It can be any caregiver with a child between the ages of 2 to 18 years. And this particular care training is designed to improve the quality of the relationship between the child and carer. So by using the research that Beck and Jess have spoken to, we've been able to extend that further and use these learnings by doing additional training into care, which will enable us to extend our reach and have more accessible training, because ultimately what we want to make sure is that we are able to reach more people. Importantly, though, without the evaluations and data like this, we truly don't know whether our service is providing the best treatment for children, young people and carers. So it's really just best practice. Like, we want to make sure what we're doing is right and getting good outcomes and based on evidence. It allows us to determine that we're using the very best treatments and that we can change and adapt them to better meet the needs of our unique families. And hopefully our engagements with families can be stronger. And really, it really helps us as a service to prioritise the training and it provides a renewed focus and commitment for scoping and undertaking literature reviews for innovative, effective and accessible treatments for children and young people.
Thank you. And what would you say are the most important aspects in terms of support for carers?
Yeah, I think we've been really focusing on how we support carers. We certainly recognise, and the research also shows, that when carers feel supported, children experience improved educational outcomes, their mental health and overall social and emotional well-being improves. So supporting carers is important for several reasons. We know that carers play a significant role in the lives of children and young people in the child protection system. They're providing the stability, the care and the nurturance, which are all essential for the overall well-being and development of a child. And it's important that carers feel supported and that they have the resources and the emotional support to meet the needs of children in their care. And when a carer feels supported and equipped to handle the challenges of providing care, the likelihood of breakdowns actually reduces. So we know that a stable placements are essential for children to form healthy attachments, to learn how to build relationships, and every child deserves to experience a sense of safety and security. Secondly, supporting the carers promotes stability and continuity in the lives of children. We can never take that for granted. When a carer feels well supported, they're more likely to provide a stable and nurturing environment, which we know is crucial for children who've experienced trauma or difficult life circumstances. This support helps to ensure that a child can form positive attachments and like I mentioned before, feel safe and develop coping strategies for them to face the challenges that they may continue to face. We know that being a carer can be rewarding, but it can also be an incredibly tough job. You've heard Jess talk about some of the studies on carers of children with maltreatment histories. It's super important to be able to offer carers treatments that address the child's issue, but also offer potential benefits for the carer as well. And I just think generally, Jess, that supporting carers benefits the child protection system as a whole. When carers feel valued and empowered, they're more likely to provide care to the vulnerable children, and that reduces the likelihood of placement disruptions and helps to maintain that stability and well-being of a child. And it really, most importantly, supporting carers is an extension of supporting our children and young people.
Thank you. Now I have one last question, and then I can see a few coming through in the chat, but please, everyone online, put through your questions. So what are the treatment options for young people with trauma when they're not case managed by DCJ?
Thanks, Jess. Yeah, this one at times it can be tricky to know where to go for a child who is experiencing trauma. And the treatment options will vary for children, young people, and their families, depending on the severity of trauma and perhaps the specific needs of the individual and the family. So most importantly, I think it is really critical that we look at a child as an individual person, and we don't try and blanket them with a response. But the treatment needs to be tailored to the child's unique needs, and it should be collaboratively between a mental health professional, the family, and the child or young person. And it also needs to consider the potential consequences of a trauma and how these needs for children and young people will likely extend beyond just psychological needs. We often talk about taking a multidisciplinary approach, so that might include occupational therapist or speech pathologist to trauma treatment, which provides a comprehensive and integrated approach that considers all aspects of an individual's life and can result in more effective and personalised care. For children that have been exposed to trauma but are currently case managed elsewhere, Psychological and Specialist Services does have a number of multidisciplinary teams. I think I mentioned it earlier around the Links Trauma Healing Services. Currently, this service is offered in 4 locations, which is Penrith, Newcastle, Illawarra and Western New South Wales. And that does provide trauma treatment, but noting that the question was for those who are also not case managed by DCJ and maybe we don't have services, some of the options that are important to explore are referrals to specialist services. So young people can be referred to specialist mental health and therapeutic services that are equipped to address trauma-related issues. There's often a lot of comorbidities that accompany post-traumatic stress. And often children will require multiple specialist interventions to address the specific symptomology and diagnoses. So these services often provide evidence-based assessments and treatments, and some of the modalities that they may utilise could be trauma-focused CBT, so that's TFCBT, and eye movement desensitisation and reprocessing, so often called EMDR. Other ways that children can be supported when not case managed by DCJ is also the importance of collaboration with external service providers. We should never underestimate the importance of working together to strengthen the system. So in many circumstances, DCJ does work collaboratively with external agencies, such as our wonderful non-government organisations or community-based service providers, to ensure that young people have access to appropriate treatment options. This collaboration allows for coordinated approaches to meet the specific needs of each young person. I mean, and if you're ever really unsure, even if children are case managed not by DCJ, typically the case managing agency should have access to internal or contracted clinicians that are able to support children therapeutically, or may help to support carers to find a suitable practitioner. I think most importantly, it's just important to ensure that young people with trauma have access to the appropriate evidence-based treatments. So I think it's knowing what are we referring the children for and where are they going? And like I mentioned before, collaboration with external service providers and interagency cooperation can help to ensure that young people receive the necessary supports to address their trauma and promote their overall well-being. So I think collectively we all have a responsibility, and if we don't know, we ask and we lean into each other to find out where can we find the best supports for this young person.
That's terrific. Thank you so much. And now we have a few questions in the chat. There's also a number of comments just, support for carers and how important that is. I have one that is 3 questions in one, so I'll just go through them in turn. So the first was PCIT, and Rebecca and Jessica, please answer these as well. Was PCIT delivered in a fixed session format, or do families move on to the next phase when they've reached competency?
So PCIT generally is based on competency, but for the purposes of this research and for this project in particular, we decided to limit the number of sessions to 25 total. Obviously, if a family was in need of more sessions, then we gave that, because again, this was a naturalistic evaluation. This wasn't a randomized controlled trial. So we really tried to meet families where they were at, but we had around about 11 CDI coaching sessions. We did 1 teaching session and 3 coaching sessions for TDI, and then about 12 of the PDI sessions. And then when we had standard PCIT, we did about 12 of the CDI sessions and 11 of the PDI sessions. And there are some additional sessions in there like graduation and an initial observation session as well. So that kind of evened the 25 out.
Fantastic. And is there a PCIT TDI manual that is available to clinicians?
Yeah, so the TDI component of treatment was developed by a couple of people in the US, Robin Gerwich and Christina Warner-Metzger. They are able to provide training to folks in TDI. We received our training online. So if you're interested in doing TDI, you can get in touch with them. I can find a link and share that later if you like as well. But there is a manual that is available and accessible once you do that training with them.
Fantastic, thank you. And the third question is, so were there baseline differences in ECBI scores between the PCIT versus PCIT TDI groups, and whether both groups of children reached non-clinical levels of conduct problems at the end of treatment?
Yep, so both groups of children did reach non-clinical levels of behavioural problems post-treatment, and all of the scores across all of the measures, there were no significant differences between the 2 groups. But I do have to preface that with just kind of saying that the groups were not evenly sized. So it was interesting that we got that result, but nonetheless, they were similar according to the statistical analysis.
Thank you. So there's another question around where the research was located. I can see there has been a response, but there's a question around, with 44% of participants being Aboriginal children, whether you had Aboriginal psychologists participating or whether you had any consultation with, for example, the local ARG around how best to support Aboriginal kids in the study.
We didn't have any Aboriginal psychologists that participated in the study, but we certainly had Aboriginal psychologists in the department that helped us kind of make sure that we were intervening in the right way. So we consulted with one of our colleagues in the Links team who provided some training to all of the team around how do we do this right? And by all means, it was not an extensive consultation process. And so I think moving forward, that would definitely be an area for us to improve our practice for sure.
Thank you. Now there's another question. I understand PCIT is a model used in LA. I'm not sure what that refers to reduce placement disruption. Is that being considered in New South Wales? And you did mention your analysis around placement change, but is that?
I think that I did see that one pop up in the chat, Jess. It was, I think they were talking about the child-adult relationship enhancement, PCIT care.
Oh, sorry.
No, you're right. We've actually just had all of our staff within Psychological and Specialist Services trained by a couple of people in the States. We brought them out so we could train the whole service in that. And that service is, I'm going to be very simplistic here, but we're short on time. So it's basically like a group-based version of PCIT for people that are between the ages of 2 and 18 years. So it's a much larger age range. So that's something that we would actually be able to reach a lot more people with and run quite regularly throughout the state. We have somebody trained in that in every district across the state.
Thank you. And this will show my lack of knowledge, but is that only for psychologists or could caseworkers deliver that as well?
Yeah, so it's any person that actually has contact with a child. So it could be a caseworker that attends that training. It could be a care team for children that are maybe in like a residential kind of placement. It can be anybody that has any kind of contact with a carer, with a child, sorry. So when we trained, we actually had a bunch of casework specialists come along, people from SIFDU, and you'll be hearing from us very soon around rolling that out to any and all of our colleagues who are interested in attending.
That's fantastic, isn't it? That's really terrific. Now, there were a few other questions, but it looks like about PCIT training, it looks like they've been answered in the chat, and we are almost at time. So I might just ask if you have any last reflections that you wanted to share with us before we draw the meeting to a close.
Look, probably no reflections from me. I don't know about you, Liz.
Look, I think for me, it is an incredible opportunity to talk about the research that we do, but just you know, how the strength of us as a service system and how we can really collectively work together to improve the experience of children, young people and their families, because we know we have to do better. So yeah, I think for me, it's just a reflection to come together to have an opportunity to think about the future and how we can improve what we do. Yeah.
Absolutely. Thank you. Well, if there aren't any further questions, and actually if you do have further questions, please feel free to either put them in the chat or reach out to our research partnerships team, and we'll put that email address in the chat if we haven't already. But I would just really like to thank everyone for joining us today. I've personally learned a huge amount, and it's obvious how important the work is that you're doing and really inspiring to know that you're on the cutting edge of research, you know, here in Australia, but also part of an international collaboration. You know, DCJ should be really proud of that work. So thank you so much. Everyone that's registered for this event will receive an email with a link to the recording. So please pass that on to your colleagues who may be interested. We'll also send out some additional links and materials related to the webinar. Some of that's been provided in the chat as well. And also we'll put that on our Lunch and Learn website. And we would also like to invite everyone to the next Lunch and Learn, which will be held on the 29th of August at midday. The title of that one is Child Protection and Health Outcomes for Aboriginal Children and Adolescents, findings from the Centre for Research Excellence REACH research program. And I'm really looking forward to hosting that one. But for now, thank you all so much. Have a fantastic rest of your day, and we look forward to seeing you again. Thank you.